So to expect a person who's morbidly obese to be able to restrict their caloric intake would require them to either feel hungry all the time for the rest of their lives or to do exorbitant amounts of exercise in order to keep the weight off. And statistics show that it just doesn't happen.
So where does that leave you? What options do you have to deal with this debilitating condition? Chances are you've tried the diets, and chances are you've had the same experience as millions of other morbidly obese Americans.
Every diet, every weight control program I tried was successful for a short period, and then I had rebound weight gain that was even more.
I did a tremendous amount of dieting. I did everything from counting calories to liquid fasting diets, the type of diets where you take shakes 3 times a day. And you know, like anybody on some of those diets, you lose substantial amounts of weight. The problem always was that the weight came back on.
The reason why diet plans don't work is because our patients are great dieters. They can lose 100 pounds. The problem is that they're never satisfied with the amount they eat. Let me give an example of that. A normal person will eat 2 pieces of pizza, be full and satisfied, and stop. A morbidly obese person or a person with this gene or this affliction will have their 2 pieces of pizza, be full, but not be satisfied, so we'll finish the pizza.
The success rate of diet, behavior modification, and drug therapy, especially for the group of patients that we deal with that are morbidly obese, is very, very poor.
Diet and exercise alone really don't allow the patient to achieve a long-term weight loss. The statistics show that a patient only has about a 2% chance of keeping any significant weight off with diet, medication, behavioral modifications alone.
According to the American Society of Bariatric Surgery, less than 5% of people in non-surgical weight loss programs lose a significant amount of weight and maintain that loss for a long period of time. In fact, according to the National Institutes of Health, most patients in these programs regain their weight within 1 year. And the record of weight loss success for people suffering from morbid obesity is poor. In an article published in the medical journal Obesity Surgery, researchers found that weight loss surgery patients report an improved quality of life, better social interactions, greater psychological well-being, more employment opportunities, and improved economic condition.
It's very clear these days that there's no other modality for treatment of morbid obesity that comes even close to surgery. Surgery affords these patients a new lease on life in almost every way. We reduce their comorbid conditions to a point where they're not taking medicines anymore in the vast majority of cases. And when they lose weight, they gain energy, they gain confidence. Their depression, at least about their weight, seems to get much better. They can interact with their families again, they can play with their kids again, they do better at their jobs. It basically starts a whole new life for them. And we talk about it in terms of being reborn, or a significant life change where things are completely different from the time they have surgery for the rest of their lives.
As medical physicians, we measure how well that patient is doing as a whole. Their psyche, their psychological well-being, their social well-being, as well as their health.
The NIH in 1991 had a consensus development panel which really outlined what the guidelines should be for bariatric surgery, and most bariatric surgeons abide by those guidelines. And thankfully, most insurance companies now abide by those guidelines as well.
The guidelines established by the National Institutes of Health state that a candidate for weight loss surgery should have a BMI of 40 or greater, or be 100 pounds or more over their ideal body weight. There are, however, exceptions. If you currently suffer from serious obesity-related health conditions and have a BMI of 35 or greater, your doctor may still recommend weight loss surgery as a potential solution to your condition. Often, in order to qualify as a candidate for weight loss surgery, a patient must demonstrate a history of attempts to lose weight with non-surgical methods. One of the most important qualifications, however, is your level of dedication. Weight loss surgery can have dramatic results, but only if the patient is fully committed to following lifelong dietary, exercise, and medical guidelines, and is dedicated to their surgeon's follow-up care plan for the rest of their life.
I think it's important for patients to modify their behavior, and I think the operation is a very strong force in helping them to modify their behavior.
I just got tired of being tired, you know. I said, this is it. I got to do something about all this weight. And change my eating habits to go along with it. I got to learn how to eat better.
At home, we always make sure that we drink our fluids before we start our meal. We always make sure that once we do start our solid food that we don't drink any more fluids after that, and for at least an hour and a half. We try and have our protein first, and then some vegetables. Usually don't prepare a starch with the meal. Don't bother eating bread with the meal. So some of those principles of success that work long term, we must apply to our daily life as well.
Whether you meet these guidelines is something you need to discuss with your referring physician or a bariatric surgeon. Surgery should not be considered until you and your doctor have evaluated all other options. Last year, over 40,000 people chose to have weight loss surgery. And according to the American Society for Bariatric Surgery, that number will grow to over 50,000 this year. We will discuss 4 options for weight loss surgery in this video: vertical banded gastroplasty, gastric band, biliopancreatic diversion with duodenal switch, and gastric bypass Roux-en-Y. Along the way, you will hear references to the terms restrictive and malabsorptive. These terms describe how different weight loss surgery procedures work.
Yeah, if you think about ways of losing weight, one is to restrict what you eat, actually not take the food into your mouth. The other way is to malabsorb the food that you do eat. That is, your body takes in the food, but your system can't absorb it, so you can't use it. So there are 2 different types of operations: a restrictive operation and a malabsorptive operation.
2 of these options we will discuss, the vertical banded gastroplasty and gastric band procedures, are referred to as purely restrictive procedures. Biliopancreatic diversion with duodenal switch and gastric bypass Roux-en-Y combine aspects of restriction and malabsorption. A gastric band procedure is also a purely restrictive surgical procedure. In this procedure, a band is placed around the uppermost part of the stomach. This band divides the stomach into 2 portions, one small and one larger portion. The band encircling the stomach can be adjusted to regulate food flow. Because food is regulated, most patients feel full faster. Food digestion occurs through the normal digestive process. A biliopancreatic diversion with duodenal switch, or BPD-DS procedure, combines a lower level of restriction with a higher level of malabsorption. In this procedure, stapling is used to create a sleeve of stomach retaining the natural stomach outlet. This stomach sleeve provides less restriction of food consumed than the other procedures discussed. In addition to restriction, nearly all of the small bowel is bypassed, causing nearly complete malabsorption of food contents. Because the new stomach is larger, most patients feel satisfied after eating. A gastric bypass Roux-en-Y procedure combines restriction with varying levels of malabsorption. In this procedure, stapling is used to create a small upper stomach pouch, which restricts the amount of food able to be consumed. In addition to restriction, a portion of small bowel is bypassed, causing malabsorption of food contents. By adding malabsorption, food is delayed in mixing with digestive juices, thus avoiding complete calorie absorption by the body. The degree of small bowel that is bypassed can result in varying levels of malabsorption. The result